Of course, thanks to everybody who is joining our call. We recognize that folks are joining from literally all over the world. So as last time I said, good morning, good afternoon, and good evening to all of you. And so I will say the same this time. So thank you very much for your participation and welcome to the second meeting of the Healthcare Ethics and Leadership Community of Interest. I know we've got some new folks on the line. So for those of you that don't know me, I'm Dr. Christine Bader. I currently serve as the director of the Griffith Institute for Leadership, Ethics, and Professionalism, as well as being the director of the Department of Defense Medical Ethics Center, or the DMEC, which may be the term most familiar to you. And again, thank you for dialing in. For the folks that weren't at the first meeting, I'd like to reiterate the purpose of this community of interest is really very straightforward. It's to create a dedicated forum for all of us to connect, network, and exchange in shared learning and mutual support as we navigate the complex ethical landscape of military healthcare. And when we all meet together and have dialogue and good deliberation, we all learn about what's occurring in the field. And collectively, we can address these ethical tensions that arise from our diverse missions, no matter where we are in the world. So as a quick reminder, for our virtual meeting, we want to ensure this session is valuable and its content is accessible to those who could not attend. So the presentation portion of the meeting is recorded. Everyone on the original invite should receive a copy within the next hour or so. If you don't, please let Ms. Combs know. And additionally, we will endeavor to post this on the DMEC website. However, we will stop the recording before the open discussion period. And this is done so that everyone can feel comfortable sharing their experiences and asking questions without their comments or questions being permanently recorded. So please feel free to be open and candid during our discussion. Again, I would like to thank Dr. Kirk, Jeannie Kirk, and Dr. McHugh for their support in putting this community of interest together, and Polly Combs, who you hear from frequently via email, who coordinates the logistics efforts. Based on the discussion and the valuable feedback we received from this community, we are pleased to announce the topic for today's session, which is prioritizing resources in a resource-constrained environment. This topic directly addresses the complex ethical dilemmas related to justice and resource allocation that you may encounter, and we look forward to delving into the ethical and policy implications of managing limited medication and pharmacy resources, any sort of resource, if you will. And with that, I will turn the floor over to Dr. Jeannie Crick. Dr. Crick, over to you, and thank you.
Hi, everyone. Good day, since it could be any time of day or night for any of you, and welcome to the session. Just like last time, I definitely am not going to take too much of your time in going over some key points that I want to share with you today. My training and background is that I have a master's in ethics and humanities and bioethics and humanities, and I did a fellowship as well in clinical bioethics. So I come at this very much from the ethics lens, and that's what informs the way that I look at these issues. So I'm going to start this presentation. Let me just share my whole screen here. I do want to give a shout out to Dr. Tyler Reese, who's also on this call, because I know that some of these slides I either stole directly from him or were made in collaboration with him when we were both back at Madigan. So to kick us off today, I wanted to first give us some context. So when we think of the term triage, we in uniform often think of this scenario: being in a real live situation on the battlefield where you're trying to decide who gets what medical care or what precious resources, and in a combat zone. But oftentimes that can also apply to our daily existence in garrison. And so today I'm going to first talk about what the situation is here, more in a garrison environment, but then I'm going to circle back around and talk about how things are slightly different from one to the other and why, and ground that in a good ethical basis for us. So To start off, many of you have seen this diagram before, and I'm sorry if I'm bringing up some PTSD from the pandemic for many of you. But when we are talking about times where we have critical shortages of resources, we're often talking about space, staff, or supplies. And so when we're trying to think of where we are in this, our natural inclination is often to say, oh gosh, we're in crisis. We need to start triaging. We need to start doing some allocation strategies. And what our job, oftentimes as leaders and as ethicists, is to take the temperature of the room down for a moment, take a deep breath, and really look at this and see where we are. So, as many of you may remember, there are conventional standards of care where in conventional times our space, our staff, our stuff is good. Like we're fine and we can practice within our usual care and do what we need to do. As we start to become shorter on any one of those three things, we can start to see how we may be having to get a little bit more creative. So the big move from conventional to contingency is that I can still provide generally my usual standard of care and that I can get to the same outcome, but I'm going to have to get creative to do it. So some people would argue that when we were standing up ICUs in tents, that we were potentially just moving to contingency because we weren't really having to practice triage principles. We were more just having to get what we would usually do, but doing things outside the norm of how we would usually get there. As we start to move further down the road, though, then we truly get into crisis standards of care. So, in crisis standards of care, we have outstripped our resources in one or more of those three critical areas. And now we really cannot achieve those usual standards of care. And it's in those moments where we have to start talking about how do we decide who gets what and how are we going to make that in those decisions in an ethical way. Obviously, there's some gray in between all of this, but the big thing that I have noticed at times when we are starting to get short on things is everybody really rushes to try to conserve supplies, which is appropriate, but we have to be careful and cautious that we are not doing so in a way that impacts our usual standard of care in a way that is detrimental to patient care. So oftentimes it's usually here. This is what we tend to see more in the garrison setting is that there's some sort of shortage of supplies and we are really in a place where we need to start conserving things. We need to start adapting things. We need to start using things in unusual ways. And I brought this up because we've seen this recently with the IV fluid shortage, but it also was something that I know I was thinking about as we were being asked the question of, well, what if we continue to have challenges getting certain resources as we face a further government shutdown? Now, obviously, there was a lot of really hard work done at much higher levels than my pay grade to ensure that we didn't run out of those things. But these were those types of thoughts that I was having. So, when we're starting to think about how are we going to prioritize who gets what and how are we going to do this, as we start to shift from that usual four principles of medical ethics, where really we're focused at the bedside, we have to take a step back and we have to start thinking more on a communal basis and a community ethics lens. And so, as we shift from that beneficence, non maleficence, respect for autonomy, we really have to focus on that justice lens. And as we get to that justice lens, we have some additional obligations that go with this. That doesn't mean that we're ignoring all those others. It's just that we also have to include these other principles. So, first of all, there's a duty to fairness. We have to make sure that those we come across as medical providers are getting fair and equal treatment. Equal is a loaded term, so I'll get there later. When we talk about duty to care, when we're in times of resource scarcity and we're truly having to make triage decisions, that care may look different than our usual standards of care, but we still have a duty to care. So, on the extreme side of the battlefield situation, when we have our expectant patients, expectant doesn't mean you just put them in a corner somewhere. And no, you provide them care. That care may look like a buddy sitting next to them and holding their hand, but it is still care. We do have a duty to steward resources. This is one I think that we're very familiar with as leaders, and that it becomes our responsibility in times of crisis. And sometimes we tend to go overboard with this, but we do have that duty under there that does underlie some of our obligations. Transparency is a big one, and one that I often bring up when I'm talking to commands about this. Our natural inclination is to, in a good way, not want to cause panic and not want to lead to people becoming more freaked out about the situation than they need to be. And so oftentimes we kind of close ranks and try to keep our exact status under wraps to a certain extent. Now, I absolutely understand the impulse for that. I've certainly experienced that myself, but we absolutely also have an ethical obligation to be transparent about where we are, transparent about what our supplies are, and transparent about how we are making the decisions to allocate scarce resources. So, getting back to the IV fluid shortage example, it was absolutely our duty to be transparent about what surgeries were being canceled and why. Now, things are going to be made in the midst of uncertainty. And oftentimes, when there is uncertainty, we don't want to display that because uncertainty can often cause fear and angst. On the contrary, we actually need to talk about that uncertainty and share that with others, because if we try to hide it, sometimes that can lead to a lack of trust. Consistency is a key one. This is making sure that our approach isn't applied unequally to different individuals. We have to be consistent. Proportionality is one that really tries to get at the fact that if you are setting your triage algorithms or whatever algorithms in some way, you need to make sure that it's not disadvantaging a certain population over another. So, an example of this in the midst of the pandemic that came up was that a lot of our triage algorithms that calculated who would get a ventilator if we ran into ventilator shortages included age as a predictor of how well someone would fare long term if they got that ventilator. Well, we were discussing about, well, what we're going to do in the case of a tie, and age came up as a proposition of, well, can't we just give it to the younger person? Wouldn't that make sense? The challenge there is that age was already incorporated when we were trying to figure out who was more likely to benefit. So if we added age in again, that was disproportionately affecting those who were older. And so you can argue that that was not ethically appropriate. And then lastly, accountability. We have to make sure that we're accountable not only to each other within our profession, but also accountable to the larger community that we are a part of. So I told you that I would circle this back to the battlefield versus garrison. The big thing here is that we have to look at what are our goals underlying each situation. And when we're talking about triaging, conserving scarce resources, it's all to achieve a mission. So on the battlefield, we talk about we have to save the most lives for the purpose of accomplishing whatever military mission we're there to do. Versus in a garrison situation, we're saving the most lives while ensuring an equitable distribution of resources. So it's that extra piece that is very different on either of those sides and may influence how we make these decisions. The other thing about this is when we're talking about the prioritization of patients, again, we have that same primary goal, saving lives. And so that really is our primary way to prioritize patients of like, what's the medical need and chance of survival here? And how can we achieve those utilitarian goals of getting, creating the best good for the best number, meaning saving the most lives, hopefully. The secondary prioritization, though, is where you start to get different. So, on the military side, there's a strong argument to be made that if you are on the battlefield, the secondary prioritization of patients after you decide medical need and chance of survival is that value to the military mission. That could be seen as ethically appropriate. On the garrison side, it's much more controversial, and you could unpack that all day long. So, I'm not going to get totally into that. I do want to bring up a couple of things here. This was one chart that was published in 2020 by Emmanuel. And what it talked about is the different ethical values and guiding principles that you can use to allocate scarce resources. So we just talked about how, and when we're talking about utilitarianism, we really try to see how can we maximize the benefits of whatever scarce resources we have. So in the case of the COVID-19 pandemic, we were just trying to maximize the life that we were saving. So that could either be in the most lives or in the most life years. So that had to do with maximizing the prognosis. And those can be slightly different. And so when it came to the COVID-19 pandemic, those typically won out when you were talking about your different triage algorithms. Treating people equally is another value that you can use to ration scarce resources. And so there's different ways to do that. So it could be a first come, first serve basis. Now, there are some problems with that, in that those individuals who are most likely to present first and most likely to have access to healthcare, especially within the COVID-19 pandemic, were already probably at an advantage to those who are coming later. So getting back to that, those principles that we have, are we disproportionately disadvantaging those who are already not able to have quick access to healthcare? The second is random selection and like a lottery. And I know that I know for me, the first time that I thought about this of really, I'm going to basically flip a coin and decide who gets what. And that seems really wrong. It actually is thought to be probably more appropriate than first come, first serve, because you are truly leaving it up to chance. And when you're talking about patients who have a similar prognosis, and that might actually be more appropriate than first come, first serve. Now, in reality, when you're just talking about like a mass casualty situation, you've got what you got when you got it. So you may have resources that are available until they're not. So first come first serve may actually be practically what you do if you don't know how many are coming, because you don't want to just steward resources without knowing that they're going to be used at the cost of others' lives. So that's a little challenging. Another one that gets talked about a lot is promoting and rewarding instrumental value. So you can either do this retrospectively, where you somehow give priority to those who have already given some sort of contribution. So the argument during COVID was that we should give priority to those who were either essential workers or working in healthcare, because they've already contributed to the fight. They've already put their lives at risk. It's really hard to actually operationalize because who truly has contributed, and it kind of gets at that instrumental value and moral worth. So it's a little challenging. The prospective is also sometimes challenging because, again, if we're using the pandemic example, this was saying, all right, I'm going to prioritize those who can get back into the fight and help with the overall mission of saving lives. Well, when this actually got operationalized, you could see that if I needed to allocate ventilators, say, and I was using the argument that I wanted to allocate this ventilator to a healthcare worker over somebody else, well, by the time that that healthcare worker was actually able to get back to work, if they ever were, if they were needing to go on a ventilator, that was going to be a long time down the road. So that one didn't hold up as well in the midst of COVID. This was published at the very beginning of the pandemic, so you can see how it wasn't as clear. Now, I will say that this is often used as a justification within the military setting on the battlefield when you start talking about maybe I should start considering that I need to prioritize those individuals who are better able to get back into the battle and win this fight sooner for us, thereby giving value to this overall situation, and that I'm going to decrease the number of lives lost overall because I'm bringing about a swifter end to the battle. There's an argument there, again, something that I can unpack all day long, so I'm not going to go there. And then lastly, there are other situations where you may give priority to the worst off. So you may actually prioritize those who are sickest first. You could see where when we're talking about vaccine distribution, that would make a whole lot of sense because you want to use preventive healthcare to maximize the benefits there. So you'd actually start with the sickest first. But when we're talking about like the COVID-19 pandemic, that didn't totally make sense. When we talked about the IV fluid shortage, on the other hand, that did make a whole lot of sense, especially early on, in that we were trying to prioritize the surgeries that needed to be done versus those that were more elective. So we were actually prioritizing the sickest first. So those are all just to give you examples of how you can set up some of your when you're talking about making these allocation decisions, some of the different ways that I think about it, and I really try to get back to these guiding principles and ethical values when I'm actually trying to get to the nitty gritty of how are we going to do this. So, how can we actually distribute these precious resources? This gets a little bit at some of those justice principles. Um, how am I going to decide who gets what? So there's just straight up equality, meaning that everybody gets the same intervention approach, versus equity, meaning everyone gets what they need. So some people are going to need more than others. There's the reciprocity, which is similar to what we talked about before with the instrumental value, whereas I serve those who have contributed. Situational value, I'm serving those who can contribute. Power is one that often makes us bristle a little, and that I'm serving those who have influence. But you can see how in a time of warfare that could be something that gets done, and that we know that there are local individuals within the local population that if we provide medical care to them, even if we have scarce resources, there's serious influence there to be gained. So something that has been looked at in the past. And then social justice, I won't get into too much today. So when we're talking about how we've talked about how we are making these decisions. Well, what about the actual nitty gritty? Like, how is this going to go? Well, on the battlefield, those who are there, presumably if you're in a true combat zone, and we're just talking about our military members, they knew when they joined that they were going to potentially be subjected to these triage decisions. So they kind of have bought into it. Versus when you're talking about a civilian community and we're all of a sudden introducing these ideas of triage, that it may not be as well accepted because everybody is so used to parsing individualistic medicine and not used to having to make these community decisions. So we saw that for sure in the times of the pandemic. Now, who is actually going to do it? On the battlefield, we know that we have triage officers assigned, and there's lots of reasons for why it is the person who it is. And in a lot of cases, it's somebody who is not part of the treating medical team. Now, usually that's because the medical team is otherwise occupied caring for the patients. But I think, oh, so sorry for my dogs barking at people outside. Um, but there is some benefit to it not being part of the medical tree on another level, in that the people who are actually providing the medical care can just stay plugged into their relationship with their patients and not have to have that conflicting relationship of, well, I have this relationship to the patients and I'm advocating for my patients, but I also have to steward my resources. So there's a little bit of something to be said for that. And we did see that apply a bit during the pandemic, in that there's this huge push to make sure that the triage decisions that were having to be made were not being made by the actual clinicians who are caring for the patients, because that would bring up this conflict that would lead to some significant moral distress. So, as we're getting into contingency moments, I wanted to bring us back to this and say, well, what can we do in these moments where we're getting critically short on things? There's a number of different things that we can do, and how it gets operationalized is really dependent on the situation. And I wanted to share with you how we applied this to the IV fluid shortage, at least here at AMC, and how I took the ethical principles and actually tried to operationalize them. And what I did was I tried to focus on these different actions that you use in contingency standards to try to address this. So I'm not going to really get into these. These are some that are sorry, I hit that too quickly. Some that are well published out there, but this really gets at, during contingency, we're doing everything we possibly can to prevent us from going into crisis. That's really what's happening here, while still providing that level of care that is at least somewhat analogous to our usual operations. Then once we get into also, while we're in contingency, we need to plan for what's going to happen during crisis. So we don't want to be caught not having thought about how we are going to make these triage decisions if we do have to get there. So not only do we need to set up whatever scheme that we're going to use, but we also have to decide who's going to do it. How are we going to do a scoring system if we're going to need to do that? And we need to practice it. So I do want to share really quickly what it was I created for the IV fluid shortage, just to show you, and I'm happy to make this available to anybody. I know I shared it with several in the midst of the IV fluid shortage, but just a quick SBAR of what was going on. But how did I apply my ethics hat when I was trying to come up with a framework so that this could be useful for commands? So I said, like, really here, this is just providing ethical principles and ethical framework to say how we can guide the organization on the conservation and allocation of fluids. So I reminded everybody of what contingency was and what crisis was, because I felt like that was a big part of my job, is to remind everybody where we were. I outlined the different ethical principles. These are those 7 that I shared with you on that one slide, and just define them for everybody. And then what I did from there was I tried to classify things, and this I did not do alone. This I partnered with several other folks within the institution to come up with some of these. But this was really getting at, how can we define the different types of surgeries, of what needs to be done and what doesn't, and then break it down into where are we based on our supply. So if we knew, what level of supplies we had, when were we in contingency, when were we switching to crisis, and how did that influence what we were doing? So can we pause the elective surgeries? We're still doing fluid conservation strategies. And then when would we truly get into triage strategies? And then if we had to move to crisis, how are we going to do that? And then my recommendations as far as triage teams. So this is the document that I put together for our commander, just to try to say, like, this is how I was looking at things in a way that we could work through it in a way that honored the ethical principles at play. So with that, I'm going to stop sharing, and I'll turn it back over to you all for either questions or back to Dr. Bader.
Thank you very much, Dr. Crick. That was, as always, another very interesting presentation. So I'm very grateful for you presenting that to the group today. I actually have a question, and then I'll